Our first session will be an English session titled Novel Devices in the Field of Aortic Valve Treatment. The chairpersons will be Dr. Hyo-soo Kim from Seoul National University, Dr. Ki-Uk Chang from Catholic University, and Dr. Youngjin Choi from Sejong Hospital. Please, Dr. Kim.
Welcome to the first session today. The title is Session 1, Novel Devices in the Field of Aortic Valve Treatment. We have eminent panels, Dr. Seung-ho Kang, Woon Kim, Manun Park, Jeo Seung, Han-chul Lee, and Taeyeon Yang. We have 5 lectures, which will be about less than 15 minutes. Then we are going to have 10 minutes discussion. Let me introduce the first speaker, Dr. Kan Zen from Kyoto Prefectural University of Medicine, Japan. His title of lecture is Technical Tips and Tricks for Nabito. Dr. Kim, please.
Can you hear me? Can you hear my presentation? Sorry, can you hear me?
Yes, we hear you, yeah.
Okay, thank you very much. Good morning, everyone. This is my great pleasure to make a presentation in front of you. I am Kan Zen from Kyoto Prefectural University of Medicine. Today, I would like to make a presentation about medical implementation technique, tips and tricks. The important feature of the Navita is that it doesn't have a spine structure like the Evolute. And this catheter have a brittle and soft character. As you know, the Evolute FX has less spine shock from 2 to 1. As you can see in this slide, Evolute Pro Plus run along the right curvature and turns in the upper portion like this, and making the angle gap between the membranes and the cover part. On the other hand, the softer shaft Evolute FX runs along the inside the center of the aorta and has more coaxially like this, and there is less gap between the membranes and cover bar. I'd like to show you the actual case in the Evolute case. As you can see in this image, at the point of no return, there is a gap between the cover valve and the nephrogenius in terms of the axis. On the other hand, in the FX cases, as you can see in this movie, at the point of no return, there is no gap, more actually inserted the valve like this. And this kind of the tendency is more pronounced in the Navita. This is a very important point. I would like to show you the Navita case. This is 88 years old female with immediate surgical risk. The perimeter is 74.2 and the SOB size is breast sufficient, and root angle is 53 degrees. From this data, I choose Navita Vision 27 from the left side transfemoral abscess. Yes, I routinely check the proper perpendicular view and crossover view of this. After checking the device, the preview necessary. I use a 20 millimeter preview. And I adjust the views using the crossover view like this. Almost, as you can see in this light movie, almost a depth is 3 millimeter. The emphasis. And let's move to the aerial view. At this point, I noticed that this valve can be moved upward 1 millimeter at this point. And with the highlight facing, I open the valve to the point of no return with a little bit putting shaft maneuver like this. The eye makes the valve position 1 millimeter higher at the spark point. And at the point of no return, I check the depth of the valve, left side of the area, and I say the password up in here and looks good. And after confirmation of the non-uniform expansion like this, and after last checking the depth confirmation, I completely open the valve. And as you can see in this movie, the valve depth looks quite good. And to decrease PDL, I made post-PAD using a 26 microphone, and as you can see in this slide, maybe I could get optimal result. That's it. And in this case, you can see the 3 mark at the bottom in the left. This latest model of the NIDA radio path marker, also which has a very clear visibility. And from the marker top to the bottom, the length is 4.5 meters. And from the marker bottom to the bottom, the length is equal to the 3 meters. And next, I'd like to show you the way of more intentional, strongly adjusting the valve technique. This is a 78-year-old female with high size pelvis and decompensated. And the perimeter is 71.8 and the root is 56. From this information, I choose the Center Vision 25 mm from the light drawing access at the PF tower. This is the popular perpendicular view and the passive wrapping view. And due to the relatively low takeoff the left coronary artery, I also made a coronary protection system. After checking the device, I used 80 mm Balance plate. And using in the cusp overlapping view, I adjust the valve tips at the 3 mm this. And I slowly open the valve to the point of no return like this. It's a little bit in that place, but as you can see in this right move, it's depth of the LCC is quite shallow. And I recapture and I try again, and I start deeper position like left side in the left area of view. And with the highlight facing, I open the valve to the point of no return with a little bit strong pulling back maneuver. And I adjust the depth of the MCC to the 3.1 millimeter, and as you can see in this right image, the depth of the LCC becomes deep. This is just check out the point of no return. As you can see in this movie, it looks good on both sides, MCC and FCC. And at the cusp overlapping view also looks good. And I slowly open the valve. The valve was completely opened and safely. As you can see in this slide, the depth of the valve looks 3 or 4 millimeters. I also use post-dilation to decrease the DDL, and as you can see that the light movement, the result is considered path. And Narita had very flexible and soft with the excellent coating surface. We can challenge more tougher access cases. You can see in this slide 3D images. There's a large amount of calcium on the tree, and from the axial GPV, the lower limb artery an area from the artery quite smaller like this. But we can perform the TF cover from the left groin. Yes. Carefully, I puncture the left femoral artery with this using the guidance. Yeah, I successfully implant this about like this, and this is the final angiography of the lower limb. As you can see in the right movement, the lower limb artery is quite small, but the hemostasis is completely successfully checked. Lastly, I want to show you the subclavian abscess case. From the 3D view, there is no chance to get the abscess from the bilateral conhumeral of this patient. Left subclavian looks good. From the actual view of the CT, the bilateral conhumeral artery covered by this curve like this. And from the left subclavian abscess, the navicular valve can be implanted successfully like this. And this is bypass images after removing the device. As you can see in this movie with the eyeglass, there is no any injury inside the left subclavian artery. So maybe this kind of devices with excellent coating is very suitable for the subclavian. As a summary, medical requiring using personal technique to reach the excellent device passing performance in levels between medical practice. Alternative approach of subclavian actually are also applied with better feeling. Navivision, the latest model has clearly developed muscle effectively for better depth adjustment. Thank you for your attention.
Thank you for your lecture, Dr. Chen. So, discussion will be done after all the lectures. Let me introduce second speaker, Dr. Anuruk from Police General Hospital of Thailand. He will introduce the technical tips and tricks for Beta Flow. Beta Flow is not introduced in Korea, so please show your details. Thank you.
Thank you very much, Mr. Chairman. It's my great honor to present my topic today. This is my disclosure. In Thailand, we have the 8 valves available in Thailand. So Vital Flow is one of our valve in the market. So let's go to the morphology of the Vital Flow. Vital Flow is made from the bovine pericardium for the leaflet, and the valve frame have the hybrid design. The upper part is a large cell, so you can see that is a low density, make the valve more flexible and less radial strength here. and the lower part is the closed cell. So it's very high radial strength, and it have the skirt. The skirt have made from the PET is the same thing as the Edward material. So the valve, it seems that it's not the very suture very tight for the skirt. It can be bulky when you put the valve have the vertical force. It will be bulky because it's a loose tissue around for the skirt, and they can have the blood coming through the hole here because the suture not close for the blood in the diastole to coming inside. So the skirt can bulky more when they put in the annulus, and it came with 4 size cover from the annulus diameter about 17 to 29. The delivery system have the unique character. It also have the motorized to make the operator we can do with the single operator because you can control the catheter and control the valve and let the nurse to press the motorized to release the valve. So that is one thing of the benefit of the vital flow. And another thing is the catheter is moved freely, so it's not jump in much like the Evolut R from the original idea of the self-expandable. But the trade-off thing that is not the thing that I don't like is the size of the catheter will be bigger than other valves in the market. Other things that is the benefit from the vital flow is the diameter of the EOA of the valve is quite a little bit bigger than the Evolut from the market. Like the biggest one, the Vital Flow 30 have the EOA of about 28 millimeter. When compared with the Evolut 34, it has 24 millimeter. So let's see the case. This is the first case in Thailand. So it's not the AS case, it's the AR case with the history of the IE. So he is the ESRD patient of the 74 years old male who has the IE in 2022, and the right chori is the right cuts have the perforation, and after that, even though we initiate the hemodialysis 4 times a week, he still have the heart failure. So this is the picture of the chest film EKG and normal chori. So he refused the surgery all the time, and he had to admit for 6 months every month during the 6 weeks before we decided to do the TAVI for them. This is the STS score. He's the moderate risk, but still refused the surgery. The guideline says that TAVI is for AI is a class 3. Why? Because AR lack of calcium for anchoring, and it have the large diameter of the aortic root and the annulus and also the aorta. So that's why it's very difficult to manipulate the valve. If we want to do it, maybe we have to increase the balloon size, so it may be cause the annular rupture, and it's very easy to cause the migration of the device, and sometimes it have the residual AR. This is the vital flow when you magnify. This is the skirt that you see. It have the gap around here, so the blood is coming and it's kind of bulky. So I reviewed the paper and also talked to the proctor from China. They allow me to do the vital flow for this case because they says that the AR case with the annular dilatation or the root dilatation, we can have the 3-point anchor from the annulus, LVOT, and the ascending aorta. This is classified as a Type 1 Aurora classification. So they not recommend only the anchoring is at the LVOT level. In our case, and the anchoring, they have the degree of the anchoring. Like the annulus, they have to oversize about 10%, and it's not more than 20, not more than 30, because if it's more than 30, it squeezes the wall and it causes the pop-up. And the ascending aorta is less than 35. So the ratio between the LVOT and annulus is more than 0.95. All of these things will be suitable for the valve expansion, not too much for the radial strength to squeeze the valve pop up. So let's see this case. the diameter of the annulus in this case is about 26, and the LVOT is the same size, 25.6, so it's quite nice. And we have no chori occlusion problem, and the leg is quite big enough for vital flow. The choice of the valve is 30, and when we measurement in the systole and the diastole is the same. It's not different much. And when we calculate for Aurora criteria, it will be the annulus LVOT ratio is 1. Oversize about 30 to 16%. And at the ascending aorta, it's oversize more, about 30%, but it have the less cell here. So it can stabilize because it can conform to the aortic root. This case is matching for the Aurora type 1, so we can do the anchoring with 3-point LVOT annulus and also ascending aorta. We choose the sentinel in this case because of the AR case. We worried about some debris can cause the stroke. So we can cause the aortic valve with the pigtail, and the gradients, it has some gradient because it's a high jet from the aortic regurgitation. So you can see the performance of the vital flow catheter. It can pass smoothly to the descending aorta, and without the calcium from the aortic arch, it can pass very well. But you can see its conformability to the arch is quite rigid, so it's not bending at the capsule and the valve inside the capsule. And the step of deployment, you have to start deployment at the same level as annulus plane, using the cast overlap like the Evolute technique. Just press the motorized, the capsule is going up, and you can adjust by using the Y pushing forward if you not like the position of the valve. And this is the things that happen when you press release from the motorized. It's quite stable. And with the nearly annular contact, we do the control pressing to make the valve more stable. And after that, I go to the LAO view and adjust the parallax of the valve and keep the tension on the catheter for a while to make the cell expandable more stronger when they stay in the body. And check the position of the valve and release the valve with the layover technique, as the Dr. Grada mentioned for the Evolute. So just slowly release centralized nose cone and just release the valve. As the technical, for me, is nearly same as Evolute technique. So it's quite stable in this case for the AR case. Okay, we can see it because I have to slow down. Yeah. This is the final result of this case. So they have no parallel. The valve sit well in the annulus, and it have no gradient when we finish the valve without any conduction abnormality. So the conclusion of this case for the first AR vital flow in our country is possible because it's the Aurora type 1. We have three-part anchoring. The sentinel cannot catch up anything, no conduction abnormality. The patient recovery very well for the next and discharge for the next 2 days. No readmission from the heart failure again. The second case is also the case that's quite unique because he is the CVAS and AR does the first surgery Saver on the 2012, and after with the Hancocks and have the valve degeneration in the 2018. And this is the third time intervention for the aortic valve because he have the trifecta failure. So the 3E show that the right cast is failed. So when we talk about the valve in valve, we quite worried about the chori obstruction and PPM. So in this case, with the supraannular design, we not worry much, but we quite worried about the the chorea of suction. So we use the vivid classification, and this case for the vivid classification, the SOV is, the valve is higher than the original of orifice of the chorea, but the SOV is very large. So we have no problem with the chorea obstruction, but we quite worried that if we have the commissural pros in front of the left chorea with the low chorea height like this, it will be very difficult to do the PCI after TAVI. So the trifecta is out of the market in July 2023 because it have the early valve degeneration, because it have the external skirt and have the problem with the commissural post tearing and cause a very rapid degeneration. In this case, he used the trifecta size 23. The inner diameter is 21. So we choose the 24 valve. And at that time, I'm quite concerned about the commissural alignment in this case because I want to access the chorea. So I think that I will use the commissural post of the vital flow as the same as the commissural post of the trifecta. The leg is have no problem. He has the high STS score, is a high risk patient. So usually you can see that the capsule of the valve is not bending. It's not a good bending like this. When the proctor from China, they always recommend to use the snare if they think that you will face the problem or struggle with the crossing the arc or crossing the valve in the horizontal aorta, so that's why the snare can change the position of the tip of the catheter. Because it's a valve in valve, so they worried that we cannot cross the valve by directly cross the valve, so they recommend us to use the snare. And this is the position that I put in. I think it's a little bit high, but it's worked very well. But the problem is when the valve is open, the commissural pole of the trifecta is gone because the density is the same as the stent frame. So I cannot do the commissural alignment in this case. And after release the valve for 80%, I try to lay over to make the valve more deeper. But with my less experience for the valve in valve, so the valve is pop up in the left side, in the right side. So this is the final result. Even though it have the pop up, it have the gap here. The valve is sit well because the radial strength is quite nice and skirt can seal the AR of this case. So when we do the CT 1 month after we put the vital flow, you can see that this is the trifecta leaflet. It helps us to seal the valve pop up here. And it's quite the function of the valve and the problem with the valve is have no problem because the gradient is good. They have no polar leak, but you can see that it have some halt happen in front of the right chorea, and this is the halt in the right leaflet RCC class. So for my conclusion, the vital flow is when compared with another self-expandable, the pro is the low density stent frame, hybrid stent design. So the lower part is have a very high radial strength, and the skirt design is very effective to correct the PVL problem. So the delivery system is quite big and less flexibility when the valve is coming inside the capsule, and no specific treatment for the commissural alignment. The deployment technique is same as Evolus, so you not have too much learning curve for this valve. Thank you very much for your attention.
Thank you, Dr. Anurag. So we are going to third lecture. And third lecture is Dr. Jeffrey Palmer from Harvard University, but unluckily he has another business, so he'll not be here on June. So his speech is shown on the recorded video. So we'll start his recorded video. Please.
I'm Jeff Popma, Vice President, Chief Medical Officer at Medtronic for Structural Heart, Coronary, and Renal Innovation. And it's my pleasure to present to the Jeju Valve Conference a talk entitled Building the Evidence for Valve Performance with Evolute from Acute Hemodynamics to Late Valve Integrity, Now and in the Future. I want to thank Dr. Cheng and Congress organizers for this important invitation. My disclosures are I'm a full-time Medtronic employee. I want to make 5 very brief points. First, we now know that transcatheter valve design plays an important role in determining late valve performance. You're all well familiar with our superannular self-expanding Evolute design with its long reverse-canted porcine pericardial leaflets, lowering the leaflet stress during the cardiac cycle. This results hemodynamically in low gradients that are sustained out to 5 and 10 years. There's a very strong inflow that's conformable to the annulus and able to seal around left ventricular outflow tract calcification. We know that the porcine pericardium is thinner, and the way it's constructed has less leaflet stress, 40% less leaflet stress, than with balloon expandable technologies. So we've known about the design. Now, more recently, I'll show you we've linked that valve design with valve performance and clinical outcomes. So as we start to treat patients who are lower risk for surgery, we have to understand the fact that the patients are younger, they'll live longer, and they'll want to have more important outcomes. So I'd like to share very briefly in a few slides what we've learned from our Evolute low-risk trial that shows superior valve performance compared to surgical valves, and at 4 years shows a trend towards improved clinical outcomes with Evolute. Now, everyone's aware of our cascade of studies from patients who were extreme risk or inoperable to those who are high risk and randomized to surgery, and those who are intermediate risk and randomized to surgery. In 2016, we began to study patients who were deemed by the heart team to be low risk for surgery, an average age of 74, an STS of 2. We randomized 1,414 patients to either TAVR or surgery, and we followed and reported those patients each year. At our TCT conference this year in 2023, Mike Reardon presented the 5-year or the 4-year results from the Evolute low-risk trial, and showed that the endpoint, the primary endpoint of all-cause mortality or disabling stroke, was progressively divergent from 1 year to 2 years to 3 years to 4 years, so that all-cause mortality or disabling stroke occurred in 14.1% of patients treated with surgery and 10.7% of patients who were treated with Evolute. Most importantly, this benefit was due to a separation in mortality from 1 year to 2 years to 3 years to 4 years, a progressive separation of the curves from 12.1 mortality at 4 years with surgery and 9% in those patients treated with Evolute. Very, very important, particularly comparing the contrasting event curves that occurred with the PARTNER 2A and PARTNER 3 trials. Now, our next step was then to prove what is the benefit of the superannular technology for TAVR compared to other annular devices like the balloon expandable SAPIEN. And we performed and presented at the ACC meeting this year with Howie Herman the results of our SMART trial, which focused on patients with small aortic diameters with a heavy enrichment with women. And we showed that there was superior valve performance in patients treated with self-expanding Evolute compared to those treated with balloon expandable. Let me show you a little bit more detail. We felt it was important that we would actually do a head-to-head comparison, a randomized clinical trial, excluding all of the unmeasured confounders that affect other sorts of retrospective analyses, even with propensity matching. So we enrolled 355 patients with Evolute and 361 patients with balloon expandable TAVR. We had 2 primary endpoints. First, we wanted to prove that Evolute was safe. So we had a non-inferior endpoint with composite mortality, disabling stroke, or heart failure hospitalization through 12 months. We also wanted to demonstrate that Evolut had a better valve performance than the balloon expandable. So we looked at bioprosthetic valve dysfunction through 12 months. I'll show you those results. First of all, we had a very strong and rapid recruitment. We had an average age of 80 years. We had an STS risk score of 3.3. But the cumulative event curve is really important to examine for our first endpoint, which was the non-inferior endpoint of mortality, disabling stroke, or heart failure hospitalization. And we found that we were non-inferior. In fact, the cumulative event curves were higher for the balloon expandable sapien valve, 10.6%, compared to the self-expanding 9.4%. Not statistically different, but numerically certainly in the right direction for Evolut. But most importantly, and I think surprisingly, we found that there was a tremendous reduction in the occurrence of bioprosthetic valve dysfunction through 12 months using components of hemodynamic structural valve deterioration, a gradient over 20, non-structural valve deterioration, severe PPM, moderate severe PVL, thrombosis, endocarditis, aortic intervention. And we found at 12 months that 41.6% of patients treated with the sapien valve had some evidence of bioprosthetic valve dysfunction, compared to 9.4% with the Evolut group. We looked at all the components in a lot of different ways, and we found that the very important flow-independent measure of Doppler velocity index showed a higher DVI, 0.63, with Evolut compared to 0.44 with sapien. Severe PPM, 10% with sapien, 3% with Evolut. And most importantly, we saw lower rates of total aortic regurgitation at 1 year with Evolut than sapien. It was 19.3% for sapien, which is a good number for the sapien randomized trials. And it was 14.1% with Evolut, we believe, because of better implantation technique, such as things like cusp overlap. We also found that there was an improvement in quality of life using the VARC3 indices of how much an improvement one gained. We found that more patients had substantial improvement in their quality of life in those who were treated with Evolut compared to sapien. So this is a first step. We'll be reporting these outcomes all the way out to 5 years. It's a first step. We found numerically better 1-year clinical outcomes with Evolut compared to sapien, and we found substantial differences in valve performance, and we'll see how those manifest over the next several years. Well, it's very important then, as the fourth point, to say we need to be able to understand whether poor valve performance, as we have measured it, is associated with worsened 5-year clinical outcome and rehospitalization with both TAVR and surgery. So we relied upon an analysis of all of our high-risk and intermediate-risk patients and our concomitant registries, 5,500 patients, and we defined bioprosthetic valve dysfunction as structural valve deterioration, non-structural valve deterioration, thrombosis, and endocarditis, and using VARC3-like criteria for a change in gradient, more than 10, and a gradient over 20 to define the structural valve deterioration. And we used very sophisticated analysis, including an analysis that looked at outcomes using death as a completing risk in this elderly population. Here's what we found. We found that first, bioprosthetic valve dysfunction occurs early. It begins to manifest itself at 30 days. And we said by 5 years, the rate was substantially lower, significantly lower in patients who were treated with CoreValve and some Evolut, 9.6%, than in those patients treated with surgery, 15.4%. So an early and sustained reduction in bioprosthetic valve dysfunction in those patients who were treated with CoreValve. We also found a very important finding too, was it wasn't just the small annuli, although there was a larger effect in the small annuli, but patients who had a CT annular diameter of over 23 also had a beneficial reduction in bioprosthetic valve dysfunction. 9.8% with core valve, and 14.2% with surgery. Here's the most important point, and that is we were then able to correlate the occurrence of bioprosthetic valve dysfunction, which began at 30 days, with 5-year mortality, 5-year cardiovascular mortality, 5-year hospitalization. And this was true in the pooled analysis, in the surgery sub-analyses, and most importantly, in those patients who were treated with TAVR devices. And these were very, very important. These were very, very important findings. Finally, the last point, that we want to understand what new valve iterations mean for us. We're not done iterating with Evolut. We want to have better stability and deployment. That's our FX design, which has a nose cone redesign, has a more flexible capsule, has a single spine shaft, has an optimized stability layer, and 3 inflow markers to assessing commissural alignment. And what this results in is better delivery, more coaxial deployment, less TAVR movement on release, and importantly, documentation of commissural alignment. And in the early experience in the United States, reported in a multi-center series by Dr. Gilbert Tang, 96% of patients had commissural alignment, which is incredibly important as we think about coronary access. Guy Adesanya then performed an analysis of now what turns out to be about 125 patients, was able to visualize 100% of patients with the right and the left coronary arteries, and by CT in those patients, found that there was really substantial commissural alignment, no post in front of the coronaries. Incredibly important for us as we move forward and thinking about coronary access in the future. And of course, our next generation valve design, which has now been approved in the United States, FX Plus, has a large cell window in the middle of the commissure to gain coronary access. So just to finish up what we've talked about over the last 15 minutes or so is, first of all, transcatheter valve design plays a very important role now in determining late valve performance, no question about it. We demonstrated that our low-risk trial has better performance compared to surgery, and that we're showing some trends in reduced clinical outcomes. We did the SMART trial, which was a randomized clinical trial reported in the New England Journal of Medicine, showing superior valve performance with self-expanding evolutes. We'll follow these patients out to 5 years to assess their clinical outcomes. We know from our prior series that poor valve performance is associated with worsened 5-year mortality, rehospitalization, with both TAVR and surgery. And we will continue to iterate and continue to come up with new valve iterations that will focus on predictability, easy access, and lifetime management. Thank you so much for your attention.
Thank you, Dr. Jeffrey. So next speaker would be Dr. Leo Ilberg. He will talk about the future direction of transcatheter pipelines. Would you please? Dr. Ilberg, can you hear me?
Good evening.
Yes.
Yeah, good evening. Can you hear me?
We can clearly hear you.
Perfect. And you can see my slides as well. Perfect.
Yes.
All right. So, well, good evening to all of you from Chicago in the US. First of all, I thank for the opportunity to speak on this prestigious meeting. Thank you for the invite. What I'm going to be doing is basically making a sidestep from all things aortic, and will be taking you on a small journey within mitral and tricuspid therapies. My name is Leo Ilberg. I'm former cardiac surgeon and former transcatheter operator. I am currently a vice president for mitral and tricuspid therapies at Edwards. And my disclosure is that I'm a full-time employee by Edwards, and that's the only disclosure I have. So when we talk about patients that suffer from tricuspid and mitral regurgitation, we know that these patients, that they are miserable, they are really having a poor life, and they are suffering from multiple different symptoms that you all are extremely well aware of treating these patients. What we currently know is that both the medical and the surgical options, they do have limitations. within Edwards, we have been putting a lot of emphasis over the past years in order to develop both transcatheter repair and replacement technologies that currently are truly transforming this space. So in this slide, I give our overall view where the mitral space right now is at. We know that the repair option with the edge-to-edge therapy has been pretty much the only interventional transcatheter treatment option for these patients for the past decades. We know that currently that option is still expanding. It continues to grow. It's supported by a strong outcomes, both in patients that have a simple pathology as well as patients that have more complex disease as well, who are sicker. We know also that there's a increased awareness of the disease. We still think that repair therapy with the edge-to-edge is and will be the mainstay of transcatheter mitral therapy going forward. However, that being said, we know that finally, after a lot of trials and tribulations, the mitral replacement technologies are just about to break through into the mainstream. And by doing so, over the next upcoming years, it will be extending the therapy options to more patients. Now I'm going to be taking you to some of the technologies that we work on at Edwards, where the first one that I'm introducing to you, that some of you might be familiar with, is the PASCAL edge-to-edge repair. In this picture, you see the delivery system of PASCAL, which is basically a 3-component delivery system called Precision. It's a catheter within a catheter within a catheter system. Everything is non-keyed in order to allow a wide range of degrees of freedom to maneuver the device to all the different portions of the mitral valve, as well as having a lot of ability to correct the trajectories within the left atrium, as well as being able to gain height and steer the system in a very finite and micro motion fashion. Here you see the picture of the actual implant. On the left-hand side, you see the PASCAL ACE implant, and on right-hand side, you see the PASCAL implant. They both share the same features when it comes to way how the leaflets are being captured in a technique as we call clasping. It's pretty atraumatic because we have only one single row of retention elements, which allows one to do a couple of things. With the first thing, that these two, they work completely independent from one another, so that you can capture one mitral leaflet at a time. And also it allows you to do basically, as we call it, catch and release and leaflet optimization pretty much as many times as you need without damaging the mitral valve leaflet structure by doing repeated captures of the leaflet, releasing it again, needing to optimize again. If needs to be, it can be done multiple times. Obviously, the goal is to get it right at the first time, but if needs to be, that feature is there with added safety. The whole implant is nitinol based. It doesn't have any hinges or mechanical locking. It's basically heat set in a fashion that it closes on itself. It's physiological, allowing to have some motion throughout the cardiac cycle. The third feature that I would like to highlight as well is the central spacer. The ACE implant on the left-hand side has a very minute spacer per se. The PASCAL implant on the right-hand side has a larger spacer that have different kind of fair use areas on occasions where we think that less leaflet stress is needed, or we think that the actual spacer in the middle will be enhancing the overall leaflet coaptation in between the two leaflets. Currently, when it comes to where we are at with generating the evidence and data on Pascal, it's basically a twofold story. We have multiple randomized trials ongoing called the CLASP trials shown here on the left-hand side. The one being CLASP 2D, which is for primary valve disease, that has been already being enrolled. The results of the full cohort at 1 year were presented last year at the TCT with simultaneous publications. It's already gained approval for primary valve indication in the US. It already has been approved for both functional and degenerative in Europe. We are conducting studies which are shown in here called CLASP 2F, which is for functional mitral regurg, as well as we are doing a study called CLASP 2TR, which is on tricuspid trial. Both of these trials are just about to close their enrollment in the near future, and we're excited to see what the data is going to be looking like. Further to that, we are also doing a real-world studies that validate these results, and Pascal mitral study called MyClasp has been showing an excellent safety and efficacy both in functional and degenerative populations. Also, the TriClasp trial has been showing a significant TR reduction and durable quality of life improvements with an excellent safety profile over time. But anyways, the overall body of evidence on Pascal device and on its benefits is currently increasing all the time. This is just showing you a one slider of results being generated. This is coming from the CLASP 2D trial, showing the main primary and secondary outcome results with respect to effectiveness in terms of MR reduction. This was assessed by an independent core lab throughout all the different time points. I'm drawing your attention to the 1 year outcome of Pascal as opposed to MitraClip with respect of the patients having 96%, close to that of a 2+ or less mitral regurg at 1 year, and as much as 77% of the patients having 1+ or less mitral regurgitation at 1 year. And you can see the corresponding numbers for the MitraClip on the right-hand side of this slide. When it comes to the future innovations of this platform, we keep on innovating. As said, the latest was to develop the Pascal Precision delivery system that has been really appreciated by the physicians. You can see a testament coming from Dr. Latib here in the bottom of the slide, and his appreciation of the precision system. We are working on a future generation iterations on the technology that are focusing on the ease of use and also focusing on enhancing the outcomes in multiple different ways how the design can be improved. The next technology that I would like you to draw attention to is SAPIEN M3, which is a mitral valve replacement technology. I guess that SAPIEN valve doesn't need no introduction to this audience. I think that you're pretty familiar with that as a TAVR technology, but SAPIEN has been used in quite a few patients for mitral as well. So there's more than 6,000 patients that have been treated with SAPIEN in mitral position, mainly in valves, valve-in-rings, and valve-in-Mac solutions. Now, M3 is a further iteration of SAPIEN in mitral. It's two-stage system having an outer duct that as shown here in this animation, after transseptal puncture, will be delivered through a medial commissure to the subvalvular space. Then after, it's going to be circumnavigating under the valve, as shown in here. So making a couple of loops around the valve, and then thereafter it's being unsheathed and released, leaving portions of it sitting on the atrial side of the valve, as shown in here. And that will be the docking station, whereafter the actual implantation of a sapient valve in a normal balloon expandable fashion is pretty straightforward procedure. We have completed the enrollment on the ENCIRCLE trial for a tier non-eligible patients. We're expecting to get an EU approval by the end of 2025, following thereafter by getting a commercial approval in the US. We're going to be drawing your attention for the last on a tricuspid valve as well, which is even more complex than mitral valve. It used to be the forgotten valve, but it's no longer that. Unlike mitral, we are actually witnessing right now simultaneously both repair and replacement options to emerge simultaneously. As said, we have Pascal system for edge-to-edge use in tricuspid as well. And then we have the Evoke, which is shown in here, which is the replacement system for tricuspid. It's a nitinol self-expanding frame, has a bovine pericardial tissue, has 9 ventricular anchors that capture the leaflets, so it's a leaflet-based anchoring. We have 3 sizes available, 44, 48, and 50. It's a sub-30 French delivery system. We currently have more than 1,000 patients treated with it, showing a predictable and repeatable procedure with an average procedure time under 60 minutes. We have shown this to be applicable to a broad patient population. Some of the results, clinical results shown, they come from a TRISCEND-2 trial where with the first 150 patient cohort at 6 months follow-up, the safety was clearly met, and obviously, as one should be seeing in a replacement valve, we pretty much virtually eliminated the TR on these patients and showed a substantial improvement in the quality of life as well. We are currently waiting to show the full 400 patient cohort at 1 year results at the upcoming TCT meeting in October at the in Washington, DC. We also witnessed that when we did these trials, we were able to extremely rapidly enroll the patients, which is typically a good indication of a substantial patient need. So we have gained some milestones lately. We got market approval in Europe at the end of last year, fast followed by approval here in the US in the beginning of this year. As I mentioned, we're going to be showing the full cohort results at the TCT this year. We are expanding our valve size matrix to a larger valve, 56. And obviously, we are working on a next generation technologies on a Gen 2, Gen 3, Gen 4. All that is in the pipeline currently. With that, I would like to conclude. Appreciate your attention and appreciate the opportunity to share some of the technologies that we work on within the mitral and tricuspid at Edwards Lifesciences. Thank you very much.
Great, thanks for your nice, wonderful lectures. The final lecture is canceled, thus we are going to have a lot of discussion time until 20 minutes later. We got information from new devices such as Navitor Vision, Evolut FX VitaFlow, and Pascal, Sapien M3, and Evoke for MR or TR. Do you have any comment from the panelists first? Dr. Kang, Kim, Park, Sung, Lee, Yang.
I have a question to Dr. Anurluk for the radial pulse of the VitaFlow. VitaFlow is not available in Korea, so we don't have experience. But we have a long time experience of Evolut series, and recently we have experience with Acrylic Neo. As we know that the Evolut series has enough radial force for the highly calcified artery valve. However, on the other hand, Acrylic Neo is relatively lower radial force compared to the Evolut series, right? So when you use the VitaFlow, so where is the level of radial pulse in between Evolut or Vita, or the stronger than the Evolut series? The radial pulse, in terms of radial pulse, please.
So the radius thing, I think for the VitaFlow, the company says that it's same as Evolut. But the Evolut skirt, when you face with the heavy calcify, sometimes it have the gap between the commissural. When you have the calcium and calcium, so it have the gap in between. When you overexpansion, sometimes you do the post-dilatation, the AI is, the paraleak is more in some case with the cell expandable. So when you compare with the Acrylic Neo, it have the very radial strength at the annular contraction, because it have the radial strength of the Acrylic Neo is changed when it's not in the annular. The annular opening is have the radial strength as same as Evolut when the is in the node 1, but other part is less. So when you face the chunk of calcium, sometimes you cannot have a good expansion of the acrylic. But for the Evolut, you can expand, you can do the post-dilatation, but the calcium, you don't have any bulky skirt to seal it. So sometimes you have to think of Edward. VitaFlow is in between the Edward and Evolut. So I love that, because when you use this valve, it's quite guaranteed for the sealing property. One of the things that I always love this valve.
And then I'm sorry. In case of Acrylic Neo, pre-ballooning is mandatory, right?
Yes.
However, in the Evolut series is case-by-case pre-ballooning, right? And then VitaFlow is, in case of VitaFlow, when you do the TAVR in highly calcified region, you mentioned that the radial pulse power is in between two known series, right? VitaFlow, and then we do a pre-ballooning mandatory or no in case of VitaFlow.
VitaFlow, sometimes you not necessary to do the pre-dilatation if it have less calcium. But with the heavy calcify, it's mandatory to do the pre-dilatation.
Let me change the subject regarding the 3 dots that is adopted by Evolut FX system as well as Navito Vision system. Evolut FX adopted 3 dots, and they say it may help commissural alignment, but I don't believe it, because the 3 dots start to separate only after we start deployment. If dots does not coincide with commissure, we have to recapture and rotate in a certain degree, but it is impossible. Which degree do we have to rotate? Thus, I don't think 3 dots in Evolut FX is not so helpful for commissural alignment. The similar situation happens in Navito Vision. They also adopt 3 dots in the distal part, about 3 or 4.5 millimeters from the bottom. Thus, I have a question to Dr. Ken Zen. What's the purpose of 3 dots in Navito Vision? Is it only for controlling depth and adjustment of coaxiality, or to avoid kind of oblique axis between valve versus ascending aorta? Or is it really helpful to adjust commissural alignment?
Thank you very much for the great question. I also think it is very important. In Japanese situation, some doctors try to adjust commercial alignment and navigate as well as evolute system, but many doctors say that it seems impossible. So nowadays, most of the people give up that kind of maneuver in the system. I think that not the system, the vision system has clear visible marker on the bottom, and this is due to this is for just only the adjusting the dips valve, I think.
I'd like to ask you, Dr. Leo. So, thank you for your lecture showing the future Edward transcatheter pipelines. And I was impressed by Pascal and EVOC. Pascal tricuspid and then EVOC also applied to the severe tricuspid regurgitation patient. There are a difference in indication of applying Pascal or the EVOC. So, can you explain the indication of each therapist?
Well, that is a fantastic question, and most likely a question that will be asked for the years to come, because you're asking and wanting to understand that which patients would be better served with a repair technology and which would be better served with a replacement technology in tricuspid, knowing that these technologies have a very different risk-benefit profiles overall. And I think that right now we are still at the stage that the time will tell. Obviously, we know that there are some anatomical criteria that might be making a edge-to-edge repair therapy to be less suitable. For instance, if you have a wider coaptation gaps in between the leaflets, if you have a very rich chordal density that might be preventing one to place the devices appropriately. And then also knowing that with some of these patients, depending on what we might be perceiving their lifetime management to be, if they are younger, we know that an edge-to-edge therapy pretty much effectively shuts the door from the future interventions, like doing valve replacement, etc. So that's on the one side of the coin. Then the other side is with a replacement technology where we know that with a higher predictability and certainty, you will be eliminating the TR, but obviously the price that you pay is a larger amount of hardware. You know that all biological prosthetic valves, irrespective whether they are aortic, mitral, or tricuspid, are destined to fail over time at some point. There is considerations around anti-thrombotic treatment, which is very different from on replacement technology as opposed to repair. So in the end of the day, there's multiple different considerations that will be playing a role in order to try to find the right place. And I would say that this discussion will be still ongoing for years in order to find what are the exactly right patients for a replacement and which are for the repair. I'm sorry it was a long winding answer, but I hope it was maybe helpful to get maybe some insights where the things are at, and I hope that it answered the question in a satisfactory fashion as well as I can right now.
Thank you. And I'd like to ask Kanchen. So after I heard your lecture in Jeffrey Palmer's lecture, it looks like the evolute FX and then Levito has similar performance in at the time of implantation. So you are experiencing both valve, and so what's your opinion about is there any difference between the Levito and evolute FX?
No, thank you very much. I think there is a little bit difference between the FX and the terms of the implantation technique. That's why due to the flexibility and the softness of the shell. As I show you in my slide, when the valve enter inside the left ventricle, FX like one spine model shaft become more coaxial to the native nerves. But on the other hand, the inhibitor's this tendency is more pronounced, especially in the horizontal animals. So as I presented as a second case, we should strongly, intentionally adapted the navicular valve axis to the native annulus more upright position, because sometimes dips on the LCC become higher, and it may cause popping up phenomenon. So that is the very important difference between the effect and the system. So we should take care of that.
I think current difference between the Navitor and Evolute Pro, Navitor system is superior to Evolute Pro because softer, easily centralized, and less parallax, and very stable during deployment. But with the introduction of Evolute FX, both systems looks very similar. Thus, I guess the stability of Evolute FX will be significantly improved, like the level of Navitor system. Thus, I think the difference between two systems may be less with the introduction of Evolute FX.
I have a question to Dr. Kanjen about the Navitor system. Your case, almost all cases, post-dilatation was applied. So I think it's because of the radial force is weak than other valve. And then also there is the impact of power valve regurgitation will be more than other valve. And that is also related with the long-term durability problems. So what do you think about this? This is very important implication for the future plan. So what do you think about that?
Thank you very much. I don't perform the not for all of the cases post-dilatation. I perform the post-dilatation only for the mild, more than the mild to moderate PVL cases, right? And as you said, that the post-dilatation method may cause a problem in future on the valve durability, but this is a trade-off between leaving the mild to moderate, more than mild to moderate PVL and thinking about the long-term valve durability. Okay, so but on the other hand, the pre-dilatation for then the implants are zero expandable valve is simply mandatory. In Japan, for most of the cases, every physician tries to do the fluid adaptation to the native. That's certainly the tendency.
The expansile force between Navitor and Evolut is not so different. The reason why we more frequently perform post-ballooning is the structure of Navitor. It is intra-annular valve. But Evolut is supraannular valve. Even though annulus level, it is not round. Supraannular level, it more tends to be round. But in case of Navitor, it is just annular level. Thus, it is not fully inflated or became a round shape. The valve leaf-like coaptation may not be ideal. That's the reason why we more frequently do a post-ballooning in case of Navitor, because it is intra-annular design. If there is certain degree of regurgitation, we have to be more aggressive. In terms of accurate, it is definitely weaker. Thus, even though it is supraannular design, we have to correct paravalvular leakage because it is weak expansile force. Thus, I think there is certain difference, the purpose of doing post-ballooning in Navitor and accurate. About percentage of post-ballooning in accurate is about 30. For my institute, about 50%. We do more aggressively post-ballooning.
I have one question. When it comes to radial force, especially radial force, which one is better between Navitor and accurate evolute flex?
They say in the initial deployment process, the evolute is strongest. But after complete deployment, the pressure against an annulus is not so different between evolute and Navitor.
I'd like to ask to Dr. Leo. So, you introduced the M3 for transcatheter mitral valve replacement. Recently, especially in Korea, in elderly people, the mitral annular calcification induced severe mitral stenosis. The population is increasing, but the treatment option is few. The surgery is very dangerous or no transcatheter therapy. So in the future, the M3 can be applied to such kind of MAC patient. So what do you think about that? So
yeah,
it's possible?
yeah. I mean, that is for sure. It's an opportunity under investigation. We have, as a part of the Encircle trial that I mentioned, where we have finished the enrollment of the primary cohort, we also have an arm for the patients that have a severe mitral annular calcification as well. And it's under a certain circumstances for sure a technically feasible option, and the initial results what we have seen and observed thus far seem to be relatively favorable to it. Obviously, there's some limitations. You need to have the ability to circumnavigate the docking station in the valve, but from a sealing standpoint and all that, and from expansion standpoint, to create a sufficient valve opening area, all that seems to be extremely favorable. So I'm pretty confident that it will be a good and viable option for a good selection and good proportion of patients with a calcific disease in mitral as well.
Also, I'd like to ask the procedural aspect of M3. The first step is wrapping around the mitral valve apparatus. It looks like very difficult. Edward already performed clinical trials. The doctors doing the M3 implantation suggest such partial difficulty, or it's very looks like difficult?
Yeah, yeah, Dr. Chang, you're alluding to obviously the most complex piece of the actual procedure, which is placing the duct and circumnavigating under the valve. Obviously, that's done currently under a fluoroscopic and echocardiographic control. That being said, we are currently working on doing some design iterations in order to make that to be easier and increasing and enhancing the ability how we can do that circumnavigation better going forward. So it's still a thing that improvements are needed. What we have experienced thus far is that there's variability. We see some of the cases going extremely fast, extremely well, where the placement of a docking station is just a hoot. But obviously we have experienced some challenges as well with that. So we have to put a lot of emphasis on the case support, on the appropriate training of the operators in order to acquire the skills needed for that as well. But we have good plans in place how to do that in a broad scale.
The hardest issue in this session is comparison between SAPIEN 3 Ultra versus Evolut Pro, or in the near future, Evolut FX is available. Thus, how do you think about the smart RCT panels? In small annulus, we all expect the orifice area is wider in Evolut system than SAPIEN. Thus, in a certain aspect, we can expect the results of a smart RCT. Even with this RCT, some guys insist so SAPIEN is good for small annulus patients, while another half of the physicians support Evolut system. How do you think about your opinion from Dr. Kang? Short answer. Is the results affecting your decision to choose between two valves in these small annulus patients? Dr. Kang? No? Dr. Kim?
Yeah, I think it's a smart trials show that valve deterioration is on the win for the self-expandable valve. Very small annulus area is like on the SAPIEN 320 millimeter. I think it is on the ppm or other issues. I think it will be better for use the self-expandable valve.
How about Dr. Yang? Yeah. Did these results affect your decision to choose valve between two?
Yes, I agree on the Dr. Kim's opinion. And here in Korea, we have a very small annula. It's below 400 or 350 in annular area. So in such a patient, Evolut valve is a better performance in hemodynamics, and even clinical outcome is better, I think. But there is no demonstrated result. In my case, with a very small annular area, I would like to implant Evolut less than SAPIEN.
How about Dr. Che? Short question. Evolut or
rather-
still SAPIEN?
It could be depends on the patient's situation, the anatomical and clinical profile, with limited longevity. I will rather use easy-to-use device.
Okay. How about Dr. Zhang?
I expect future SAPIEN Ultra Regilia will be the competitor to Evolut system. But however, current SAPIEN Ultra cannot be the competitor of Evolut Pro or Evolut FX in patient with small annuli. That's especially in Korea, many patients has small annulus. So the several years follow-up shows the significant increase in the transvalvular gradient after SAPIEN system. So I have been the long-term supporter of SAPIEN valve. So as a fan, next Nezilia system will eliminate this issue, I expect.
How about Dr. Park?
Yeah, from the beginning, the type of procedure, I prefer the supraannular type valve in case of the small annulus patients. So, yeah, I prefer the cervical valve.
Okay. How about Dr. Lee, Hanchu Lee?
My choice is Evolet, but I'm curious about Dr. Hyosu Kim. How about Nevito for small annulus?
I think it is not so different from the SAPIEN. In case of small annulus, I always prefer supraannular design. But when you see the smart RCT, I really suspect in terms of the good performance, good practice of SAPIEN TAVI, because AR incidence is greater than Evolut. It is opposite to our expectation or our experience. Yesterday, Didier is the PI of this trial. He mentioned he has a lot of experience with SAPIEN. Don't tell the high instance of AR after SAPIEN valve. But I guess there is certain problem of SAPIEN TAVI in their group. I suspect they perform SAPIEN implantation with just inappropriate oversizing proportion. They may deploy a SAPIEN just 0% oversizing or undersizing. Because they have a lot of experience with SAPIEN, they experience certain rupture cases, thus they adopt recessive, more conservative deployment strategy of SAPIEN. That may lead to AR more prevalent than Evolut and really high residual pressure gradient. That is the main driver of the loss of SAPIEN valve in comparison to Evolut in smart RCT. Thus, in my opinion, overall, small annulus patients, we prefer Evolut. But if SAPIEN is necessary, we don't forget about the full dilatation and achieve as wide effective orifice area as possible. That lead to less difference between two valves in even small annulus patients. Okay, and time's up. Thank you very much for 4 speakers and for our panelists. I conclude this session.